Good morning, everyone. Thank you for coming. I'm Dr. Michelle Reed from the Department of Pathology, and it is my pleasure to introduce Dr. Jill Koshiol from the NCI. Dr. Koshiol received her PhD in epidemiology from the University of North Carolina at Chapel Hill in their School of Public Health back in 2005. And then she moved on to the NCI, where she was first a cancer prevention fellow in their genetic epidemiology branch, followed by, again, she was a cancer prevention fellow in the infections and immunoepidemiology branch in the NCI back in 2008. In 2010, she became a tenure-track investigator at the NCI, and has had the courage, I think, to take on what I consider one of the most orphaned and almost homeless organs in the GI tract, and that's the gallbladder. And she focuses her research on the role of immune stimulation and inflammation in carcinogenesis, and the identification of unique molecular cancer subtypes, as well as potential outcome associations. She has numerous publications on gallbladder and other hepatobiliary cancers, and has collaborated with her colleagues in Chile as well as here at Emory University on several studies involving the gallbladder, including gallbladder mapping, a study that was recently accepted for publication in Human Pathology. She is also the principal investigator for the Shanghai Biliary Tract Cancer Study. She leads the Biliary Tract Cancer Pooling Project, as well as the Chile Biliary Longitudinal Study, a study that is worth over $10 million in NCI funding. So through these ambitious studies, she will evaluate immune response and inflammation in hepatobiliary cancers and their role in cancer prevention. On a personal note, we have been working together on several collaborative projects, including classification terminology of gallbladder dysplasia, as well as pancreatobiliary malfunction-associated molecular abnormalities. And this is a combined Emory NCI project that was initiated by Drs. Adze and Muraki several years ago. Dr. Koshiol, on a personal note, loves to dance. She's an excellent singer. I've heard her sing, and she runs 5 and 10Ks in her spare time. So Dr. Koshiol, welcome.
Thank you very much, Michelle, for the kind introduction, and to all of you for giving me the opportunity to speak with you today. I'm really excited, actually, to share with you some of the work that we've been doing on gallbladder cancer. This is a rare cancer here in the US and many parts of the developed world, so we don't know a lot about it. But there are places where it's really a hot spot and actually a leading cause of cancer death. And that means that there's a lot that we can do. The work that we do to understand this cancer better can potentially be used for cancer prevention and treatment. So I'm excited to share some of what we've been doing with you today. And I hope to get you interested in it. Everything I'm going to show you is really the result of many years of international efforts. We need teams to do this kind of work. So the more I can get other people interested and engaged, the more we can really learn and move things forward. Today I'd like to start by giving you some background on gallbladder cancer, and then I'll describe a few areas where we're working at this time. And finally, I'll wrap up by telling you about the cohort study that we're doing right now in Chile to try to move the field forward. So beginning with background. As you know, the gallbladder is part of the biliary tract, which takes bile from the liver to the small intestine to aid in the digestion of fatty foods. And the role of the gallbladder is to store and concentrate that bile until it's needed. But why should we care about gallbladder cancer? Well, for one reason, I think that gallbladder cancer is a very good model for trying to understand inflammation and how inflammation contributes to the development of cancer. And that's for a few reasons. First, gallstones are the single most important risk factor that we know about for this cancer. The vast majority of gallbladder cancer cases present with gallstones, and gallstones cause a lot of inflammation in the gallbladder. Also, other proposed risk factors have an inflammatory component. Things such as infections like Salmonella typhi, and obesity, diabetes, metabolic syndrome, which are increasingly understood to be inflammatory conditions. This is also an unusual cancer, and it's one of the few cancers that's actually more common in women than in men. And as I mentioned, this cancer is rare in most of the world, so it's something we don't know a lot about, and therefore it's an area where we really can make a lot of progress. In this figure, you can see the age-standardized incidence rates per 100,000 for gallbladder cancer across the world. And what you notice is that in much of the world, gallbladder cancer is pretty rare, less than 1 to 1.5 per 100,000. But there are regions where this cancer is really problematic. For example, southern central Chile, where the rates are about 16 per 100,000 in women and 5 per 100,000 in men. So compare that to the US, where the rates are about 1 per 100,000 in women and half of that in men. Gallbladder cancer is also a very fatal cancer. Overall, 5-year survival is about 15 to 20%. But if you can catch it early, survival is much better. While it's still localized, survival is about 42%. And if confined to the muscularis, survival is 90% or more. Unfortunately, only 10% of gallbladder cancer cases are caught while they're still local. So there's a lot of promise here, because if we can catch the cancer early, we can cure it by removing the gallbladder through cholecystectomy. But we clearly have a lot of work to do a better job of early detection. And I'm going to come back to that later when I get to inflammation markers. So what do we know so far about gallbladder cancer? Well, first, as I mentioned, the main risk factor that we know of is the presence of gallstones, which do cause chronic cholecystitis in the gallbladder, and together with additional cofactors, potentially obesity, infections, or other inflammatory conditions, lead to increasing molecular changes that drive the progression to metaplasia, dysplasia, and then cancer. So according to this model, there are two main components to think about with gallstone-related gallbladder carcinogenesis. First, what are the risk factors for gallstones? And then, once you have gallstones, what are the risk factors for cancer? So some of the risk factors for gallstones include things like age, sex, diet, obesity, physical inactivity, etc. And then if you look at some of the risk factors for gallbladder cancer, you'll notice many of these risk factors are the same as those for gallstones. This means that things get a little bit complicated when you're trying to understand to what extent do these kinds of factors affect your risk of gallbladder cancer. Is it only through their increased risk of gallstones, or do they have some kind of independent effect above and beyond that of gallstones that affects the risk of gallbladder cancer? And that's a challenging puzzle to tease out because, again, the vast majority of gallbladder cancer cases have stones, and yet only 10 to 20% of the general population have stones. So it makes it hard to figure out this second piece. Now, the prevalence of gallstones does vary throughout the world, and in this figure you can see the results of a number of ultrasonographic studies of the prevalence of gallstones. So you see in some places like Japan and Taiwan and Thailand, the prevalence of gallstones is pretty low. But there are other areas, even in the US, among the Pima Indians, for example, where the prevalence of gallstones is very high. And that's also true in the Mapuche Amerindians in Chile. We'll come back to the Mapuche briefly when I get to the Chile study. So one of the things that is of increasing interest in the world of carcinogenesis is the role of obesity. Obesity, as you know, has been increasing dramatically. According to data from a recent pooled analysis with information from over 200 countries, 12% of the global US adult population right now is obese, and over 35% are overweight or obese. And as you can see by this figure that shows the prevalence of BMI categories in men, these trends really have increased quite dramatically over the last few decades. So these categories, which represent overweight and obesity, are taking up a larger and larger proportion of the general population. And in fact, by 2025, it's estimated that 18% of men and over 21% of women will be obese, and that a substantial proportion of those will be severely obese. So we know that this is a problem and an increasing problem. At the same time, we are learning more and more that obesity contributes to the development of a number of cancers. And in this figure, you can see the proportion of cancers that are attributed to obesity globally. And what I'd like you to notice here is that both the US and Chile are among the countries that have the highest proportion of cancers attributable to obesity. And that's relevant because it means that what we learn about obesity-related cancers in Chile can inform what we need to know about obesity-related cancers here in the US. So to try to understand the extent to which obesity contributes to the development of gallbladder cancer, I worked with a group involved in a pooling project in the NCI Cohort Consortium that involved 19 cohorts with 567 gallbladder cancers. And this is a great example of why we need these kinds of pooling efforts. So each of these cohorts contributed a relatively small number of cases, but together we had enough cases to really be able to evaluate the impact of obesity with over 20 million years of person time. And you can see in this spline that shows you the risk of gallbladder cancer associated with increasing body mass index, that for every 5 kilogram per meter squared increase in BMI, there was a corresponding almost 25% increased risk of gallbladder cancer. So certainly a very strong association with obesity and gallbladder cancer. Now, among those cohorts that also had information on waist circumference, we saw about a 10% increase risk in gallbladder cancer for every 5 centimeter increase in waist circumference. So something seems to be going on here with obesity and gallbladder cancer. But to remind you, obesity is associated with risk of stones, and obesity is associated with risk of cancer. So we wanted to try to understand, is that increased risk only because obesity increases your risk of stones, or does it do something above and beyond the risk of stones? Now, to try to get at that, what we did was we restricted to those cohorts that had some information on gallstones, and then we limited the analysis to people who did not report having gallstones. So in all of these cohorts, among people who did not report having gallstones, obesity was associated with a more than 2-fold increased risk of gallbladder cancer. But this isn't a perfect measure because these are based on self-report, not on ultrasound, and stones don't always cause symptoms. In fact, most people with gallstones don't actually know that they have gallstones. In addition, most of these measures were taken at baseline, and people can develop gallstones later on. So we know that there's some imprecision here. So we thought, okay, well, let's try looking at the people who reported having gallstones and to see what's the association with obesity among those people who did report gallstones. Now here we had smaller numbers, so there were fewer cohorts that could give us estimates. But among those that did give us estimates, we actually didn't see any association between obesity and gallstones. But this isn't perfect either because, of course, once you have stones, you're more likely to have a cholecystectomy. And once you have a cholecystectomy, you are no longer at risk of developing gallbladder cancer. So I think taken together, that suggests that we can't answer the question very well using this approach as to whether or not obesity really contributes in addition to gallstones to the risk of cancer. To do that, we need to look at a cohort of people who have gallstones. And I'm going to come back to that a little bit later in this talk. But before I go on, I do want to tell you about some exciting new findings that we have on aflatoxin. So aflatoxin, as you may know, is a toxin that's produced by a couple of different family of fungi, Aspergillus flavus and Aspergillus parasiticus, which grow on corn, peanuts, certain spices. We've known for a long time that aflatoxin can cause liver cancer. But up until recently, nobody had ever actually looked at aflatoxin in gallbladder cancer. Now, that's interesting because there is actually experimental animal and occupational data to suggest that aflatoxin might cause gallbladder cancer and other biliary tract cancers. And in fact, in Chile, we have seen evidence of aflatoxin exposure, including on things like red chili peppers. Another interesting thing about Chile is that that country has a very low prevalence of hepatitis B virus and hepatitis C virus, so it doesn't have the cofactors that often go along with liver cancer. So the liver cancer rates are low in Chile, gallbladder cancer rates are high. We're seeing evidence of aflatoxin exposure. There was some prior evidence to suggest aflatoxin may be related to gallbladder cancer, and yet nobody had actually looked directly in humans to see, is aflatoxin exposure associated with gallbladder cancer? So fortunately, we had some data from a case control study, a small pilot study that we conducted in Chile from 2012 to 2013 in 3 main sites, Santiago and Concepcion and Temuco. And Concepcion and Temuco are actually in the area that's at particularly high risk of gallbladder cancer. We recruited controls matched by age, sex, and site. And then we went to John Groopman's lab at Johns Hopkins University and tested the plasma samples from 36 cancer cases, 29 gallstone controls, and 47 population-based controls for aflatoxin-albumin adducts. Now, these adducts reflect about the last 3 weeks' worth of exposure to aflatoxins. It's better than urine measures, which show you about 8 hours or so worth of exposure, but it's still kind of a limited time window. And in this figure, you can see the levels of aflatoxin lysine per albumin levels in population-based controls, gallstone controls, and gallbladder cancer cases. And what you'll note is that the cancer cases are both more likely to have detectable levels, and they're much more likely to have higher levels than either gallstone controls or population-based controls. And in fact, when we compare cancer cases to population-based controls, the cancer cases were 13 times more likely to have detectable levels than the population-based controls, and 9 times more likely than the gallstone controls to have detectable levels. So we thought this was super interesting and exciting. And in fact, the Chilean government was interested enough in this that they went out and tested a bunch of different brands of merquén, which is a spice blend that includes ají rojo, or the red chili pepper. And they found one particular spice blend, the Marco Polo blend, didn't have aflatoxin, but it had ochratoxin A, which is another mycotoxin. And because of that, they ended up pulling that brand off the shelves. So this really impressed us because we've had this striking finding. It's very interesting, but it's really based on a very small number of cases and controls. And despite that, it led the Chilean government to go do some testing that had them withdraw products from the shelves. So now when I go to Chile, my friends all ask me about aflatoxin and merquén. So these are impressive in that they are having a big impact. The work that we're doing there is making waves, and that's both exciting and a little bit frightening because it means we have a big responsibility. So we wanted to follow up and see, can we actually validate this somewhere else? And we decided to do that in the Shanghai biliary tract cancer case control study. I want to tell you a little bit more detail about this study because it's going to come up in the next section on inflammation markers. This was a population-based case control study that was conducted by Dr. Ann Singh when she was at the NCI in the late 1990s to early 2000s. She recruited 627 biliary tract cancer cases, including 363 gallbladder cancer cases, over 1,000 controls with biliary stones, and 900 healthy controls. And what I did was that I took 250 gallbladder cancer cases who had serum available for testing, actually plasma available. Of those, 209 had gallstones, so our primary analyses were actually based on those 209, and 250 gallstone controls. Again, I went to John Groopman at Hopkins University and tested for aflatoxin-albumin adducts. We found that 32% of the gallbladder cancer cases had detectable levels, compared to only 15% of the gallstone controls, for an odds ratio of 2.7. And again, looking at the levels, so here among people who have detectable levels, you can see that the gallbladder cancer cases indicated by the dotted line had higher levels than the gallstone controls. And if we compare the highest quartile to the lowest quartile, the odds ratio was 7.6. So it was good to see this validation in an entirely separate study population conducted at another time. We wanted to get a sense of, crudely, to what extent might aflatoxin be accounting for gallbladder cancer in Shanghai and in Chile. So in Shanghai, the prevalence of the exposure among gallstone controls was 15%. And the crude odds ratio for detection in cancer versus controls was 2.7, which gave us a population attributable fraction of 20%. So this suggests that up to 20% of these cancer cases might be due to aflatoxin. In Chile, the prevalence of exposure was 24% in gallstone controls, and the crude odds ratio for cancer versus stones was 5.6, which gave us a population attributable fraction of 52%. So up to 52% of cases in Chile might be due to aflatoxin. And one thing I want to point out is that in Shanghai, people had realized that aflatoxin was causing liver cancer. So they were actually working on reducing aflatoxin exposure. By the time we tested these samples, exposure was going down, whereas in Chile, nobody knew this was a problem up until very, very recently. And so there's been no efforts at aflatoxin abatement. That suggests that this population attributable fraction may be a more accurate measure of what's happening in Chile at this time. So to put this in perspective, biliary tract cancer mortality in China has been decreasing. It's gone down 22.5% from 1990 to 2013. And similarly, as I told you, aflatoxin exposure has been decreasing. So this figure is from a study conducted in Qidong, just across the river from Shanghai. And you can see that samples measured in 1982 all the way down through 2012 had this decreasing trend, with median aflatoxin-albumin adduct levels going from 19.3 in 1989 down to undetectable in 2012. The reason this is irrelevant is because the samples that we tested, that I just showed you data for, were collected right in the middle of this drop-off period, whereas in Chile, there hasn't been a drop-off like this. Now, the next logical step then is to see if we can identify aflatoxin before the cancer developed. And to this end, we've been trying to make use of two existing cohorts: the Shanghai cohort study conducted in the late 1980s, and the Shanghai Women's Health study conducted about the same time period as our case control study. So the 1980s study is useful because that, again, is before the main drop-off in aflatoxin exposure. Shanghai Women's Health, we know that there'll be some exposure because we've seen it in our case control study, but we also know that there's likely some misclassification because people who had been exposed back in the 1980s and are no longer exposed in the late 90s and 2000s won't show up with our aflatoxin-albumin measure, which only measures about 3 weeks worth of exposure. This work is still ongoing, so I don't have any data for you yet from the Shanghai Women's Health study, but I do have some preliminary data from the Shanghai cohort study. I'm really excited to share this with you today. So here we saw in the Shanghai cohort study an odds ratio of about 2. Really frustratingly for me, the lower bound is just not quite statistically significant, but it is very, very close. And I think that it is certainly consistent with what we've been seeing in the case control studies. So taken together, we see strong associations between aflatoxin and gallbladder cancer in case control studies, both from Chile and from China. And the preliminary data that we have from our cohort evaluation also supports an association between aflatoxin and gallbladder cancer development. And I think that's important because it suggests we might be able to do something to reduce the burden of disease in places like Chile or other areas where there's aflatoxin exposure by working on reducing exposure to aflatoxin. This is something that has worked in China, and it may be able to work in Chile or other places. One other area that I think we may be able to have an impact on public health is by making use of inflammation markers. So, as Michelle told you, I'm particularly interested in trying to understand how inflammation and immune response leads to the development of cancer. And one of the ways that I wanted to try to dig into that for gallbladder cancer was by looking both at circulating inflammation markers and at local inflammation markers. Circulating markers are nice because you can get blood pretty easily and you can get it from normal people. But these markers reflect inflammation from throughout the body, and that may or may not tell you about what you're interested in, the specific site that you're interested in. local markers can tell you about inflammation going on at the site that you're interested in, but it's not so easy to get those from normal people. Now, fortunately, from the Shanghai case control study, we do have some bile samples available, so we can look more locally at the gallbladder. But in general, normal people don't want to give you bile, and even though an assay works well in blood, for example, that doesn't mean that it's going to work well in bile. So you have to validate any new assay for any new specimen type. So we wanted to try to do this through, again, the Shanghai biliary tract cancer case control study, because we had these bile samples available. And we found that after extensive trial and error, we could get most markers on the Luminex assay to work in bile. But some markers didn't work well, and one of the ones that did not work well was C-reactive protein. We were particularly interested in C-reactive protein because it's produced by the liver, so we thought this might be especially relevant for gallbladder. So we also used the mesoscale plate-based ELISA kit, which did perform better for C-reactive protein. So moving forward with these two assays, we tested bile from 44 gallbladder cancer cases and 134 gallstone controls. Most of those cases and controls had pre-surgery serum available, so we also tested the serum with these two assays. And here you can see the odds ratio and 95% confidence interval for the highest versus the lowest category of 18 markers that were significantly associated with gallbladder cancer compared to gallstone controls, both in bile, indicated by the black circles, and in serum, indicated by the white triangles. And what we saw was that most of these markers had strongly elevated levels in cancer cases compared to gallstone controls, both in bile and in serum. And just to remind you, this null value of 1 would indicate no difference between cases and controls. What we're actually seeing with the log scale here is really striking differences between cases and controls. In fact, our strongest odds ratio was for IL-8, measured in serum, with an odds ratio of almost 100. And looking again at C-reactive protein, again we saw a strong odds ratio, and that was pretty similar both in bile and in serum. So because we saw associations that were fairly similar in bile and serum, we thought, okay, it's okay to try to validate this or replicate this using serum samples. So we went back to the Chile pilot study where we had serum samples available. And here you can see the odds ratios and 95% confidence intervals, again, for the highest versus lowest level of these markers in cancer cases compared to gallstone controls, measured in the Shanghai study indicated by the black circles and in the Chile study indicated by the white circles. And what I want you to notice here is that the pattern of associations in these two different studies is really quite similar. And again, we have strikingly strong associations, with 8 markers having odds ratios greater than 5 in both studies, and 17 markers having odds ratios greater than 3 in both studies. So to try to get, and to mention, C-reactive protein was again very consistent both in Chile and in Shanghai. So to try to get a little bit more precision on these estimates, we then expanded the study in Shanghai to include more gallbladder cancer cases and more gallstone controls. And in this study, where we had 144 gallbladder cancer cases, we found that about half of the markers that we looked at were associated with gallbladder cancer, and that 7 of the markers were actually associated with early stage 1, stage 2 gallbladder cancer. When we put those 7 markers all together in one logistic model to see which continued to independently predict risk, 4 markers were retained. We then took those 4 markers and created an inflammation score based on the combination of those markers, and found that for that score, looking at the highest quartile versus the lowest quartile, we had an odds ratio of 42. So again, pretty striking findings. And to give you some idea of why I think this might be important and relevant for gallbladder cancer, and in particular for early detection, let me give you some background and tell you that in Chile, gallbladder cancer is such a problem that the government actually prioritizes people aged 35 to 49 for cholecystectomy. So anybody aged 35 to 49 who shows up with gallstones, whether they have symptoms or not, is by law required to be able to have cholecystectomy within 6 months. What that means is that everybody age 50 and above who is actually at greater risk of developing gallbladder cancer has to wait, and sometimes they have to wait for years. At the same time, there may very well be overtreatment going on in these younger people for surgery which, while has a relatively low morbidity and mortality, is not without risk. So we think that these markers may be useful in this context by helping us identify the people who really need to go to surgery first. So let's take, as a hypothetical example, 1,000 people with gallstones in Chile who are waiting to have cholecystectomy. In this particular region that has very high risk, 10% of these people may have gallbladder dysplasia or cancer. And then let's take that inflammation score that I just showed you, and let's plot sensitivity on the y-axis and specificity on the x-axis. That gives you this receiver operating curve with an area under the curve of 0.89. We can use this curve to identify a cutoff with 90% sensitivity, which gives us a corresponding specificity of 67%. Now you might say, okay, 67% specificity is awful. We don't want to use that. But keep in mind, all of these people are already on the waiting list for surgery. They're all going to surgery. We just want to know who we should send to surgery first. If we take this particular cutoff and apply it to these 1,000 hypothetical people, 391 will be positive for that marker. And those 391 people will include 90% of our cases. So by shifting a little less than 40% of our list, we can actually capture the majority of the people who would really most benefit from this surgery. So we think that this is an area that has promise. But keep in mind, this is all based on people who have cancer compared to people who don't have cancer. So it's really a best case scenario. To get a more real world sense of whether this may be applicable, we're currently working with the Chileans to conduct the cholecystectomy risk stratification study. So this is a study that will ultimately recruit about 17,000 patients who are going to surgery for gallstones in Chile right now. The purpose of this study is to try to understand, can we actually use these inflammation markers to identify people with gallbladder dysplasia and cancer? So far, we've enrolled over 1,500 patients, and we expect to complete enrollment a little bit later this fall. So here you have to stay tuned, but we're hoping that this will show us, can these markers really work in a more real-world type of setting? One other piece that I wanted to show you related to inflammation markers was survival. So we took our 144 gallbladder cancer cases and looked to see how inflammation markers were related to survival. We found that 8 markers were associated with survival, and these 7 were associated with worse survival. So higher levels of these 7 markers had poorer, shorter survival. Whereas for trail, there was actually improved survival. We think that this may be useful because some of these markers, such as IL-6 and trail, actually do have therapies that are currently being evaluated for other cancers. So that might potentially have some relevance here. The other thing that I find particularly interesting is this pattern of inflammation, that gallbladder cancer cases who have a lot of inflammation generally seem to do worse. So we tried to follow up on this in one way by looking at the UK claims database, the CPRD database, and there we found that gallbladder cancer cases who were taking aspirin actually have improved survival. I find that suggestive. We need to replicate it in other places, but if it's true, it suggested to me that we might be able to help these patients just by trying to bring down their inflammation with anti-inflammatory drugs. Something worth thinking about. Now, although the results that I've shown you so far are pretty striking and interesting, for the most part, they're based on comparing people who have cancer to people who don't have cancer, cross-sectional looks. But to really understand if any of these things are related to the development of cancer, we need a prospective study. And that brings me to the Chile biliary longitudinal study. Chile is a great place to look at gallbladder cancer because the rates of gallbladder cancer are so high here. In Chile, gallbladder cancer is the third highest cause of cancer incidence and the second highest cause of cancer mortality in women. And the highest rates are in the southern central region of Chile. This area is also an area that has a very high concentration of the Mapuche Amerindian tribe, which has led the speculation that there might be a genetic component related to this cancer. But Mapuche ancestry is also related to other factors such as diet and behavior and also lower socioeconomic status. There's a lot to tease out related to that. There are many exposures of interest in this particular area, including genetic admixture, fungicide usage. There's a lot of agriculture and people are growing fruits and vegetables which require daily application of fungicides, something that has not been well evaluated in previous studies of pesticides. Salmonella enterica serovariant typhi exposure, which in the past was endemic in Chile and may therefore affect risk in people who are developing cancer now. Heavy metal exposure, as well as aflatoxin, as I've described. And there's this constant overriding need to do a better job of identifying those people who are at the highest risk so that we can send them to cholecystectomy in a timely manner. Keep in mind, if we can identify this cancer while it's still confined to the muscularis, 5-year survival is 90% or more. But if we don't, 5-year survival is less than 20%. So this is an area where we need to do work. If we can find ways to send people to surgery early, we can make a big difference. So the purpose of the Chile Bill study is to investigate predictors of gallbladder dysplasia and cancer, which I'll abbreviate as GDC. Our primary exposures of interest include inflammation markers, ultrasound characteristics such as the thickness of the wall of the gallbladder, and obesity and metabolic syndrome. We're also interested in, as a secondary aim, in trying to understand to what extent the effects of obesity and metabolic syndrome may be mediated through inflammatory pathways. So to conduct this study, we're focusing on the high-risk region of Chile, and we're focusing on women aged 50 to 74. Women, because they're twice as likely as men to have gallstones and twice as likely as men to have gallbladder cancer. But our Chilean colleagues are actually conducting their own separate Chilean-funded cohort study in this area of Maule, the Maupo cohort. So from that cohort, we'll have a separate independent comparison to men, which is useful to us. And the idea is to conduct ultrasound to identify women with gallstones. We'd like to get to a cohort of 5,000 women with gallstones and follow them up for 6 years. We expect that over the course of the study, through the normal public health system, about half of these people will go to surgery. So taking into account follow-up, loss to follow-up, we think that that's probably about 2,000 patients who will go to cholecystectomy over the course of the study. And that from those patients, there will be about 220 gallbladder dysplasia and cancer cases at about a 1-to-1 ratio of dysplasia to cancer. Now, to get to this cohort of 5,000, of course, we have to contact a much larger number of women. In fact, we have to identify about 32,000 women aged 50 to 74 because some of them won't be eligible. Actually, we found that many women have already had cholecystectomy, and therefore they don't have a gallbladder, they're not at risk, and they can't be part of the study. But of those who are eligible, we find that the vast majority are actually willing and interested in being enrolled in the study. So from these 32,000, we hope to get to 20,000 to bring in for ultrasound screening to identify our 5,000 with stones, because the prevalence of stones in this population is about 25%. We have several approaches to trying to recruit these people. First, we're going just door to door, brute force. This is really, really hard work, but I think it's also really important because it helps give us a better cross-section of the true natural history of gallstones. We don't want to bring in just symptomatic people. We want to get really the whole cross-section, which includes largely people who don't even know that they have gallstones. But we are also making use of local ultrasound waiting lists, and we're doing community campaigns where we just try to let people know, look, we've got the study going on. If you're interested in being involved, come, we'll be here on Saturday, we'll do an ultrasound, we'll see if you have gallstones. Now, for those who do have gallstones, we go on to get questionnaire data, we collect blood, we do a detailed ultrasound exam, as well as taking anthropometry measurements. And that will be done at baseline and then every other year for 6 years. Then on the off years, we're recontacting people, largely through a phone call, just to make sure that we still have their contact information up to date and that we don't lose them to follow up. At baseline, we're collecting plasma and serum, as well as a PAX gene tube for RNA expression. At the biannual visits, we'll continue to collect plasma and serum. We're not planning to collect PAX gene just because it's very expensive, but we're toying with other alternatives that might work. And then when people go to surgery, we're doing our best to get blood prior to surgery, FFPE tissue, SNAP frozen tissue, RNA later tissue, bile and gallstones. I have to say, this part has been really challenging. Getting the fresh frozen tissue is challenging. We're still working on it. We are making improvements, but it's hard. But for almost everybody, in fact, for everybody who goes to surgery, we do have FFPE tissue. And on about 80% of them, we have completely sampled gallbladders. We have the entire thing. So this is really going to be an amazing resource that will allow us to look across the natural history of disease at any part of the gallbladder. And soon, I hope that we will also have the fresh frozen tissue to help support those kinds of molecular assays. So far, we've screened over 14,000 women in Araucanía, which is the major of 2 sites that we're working in. And we've recruited over 4,000 women aged 50 to 74 with gallstones from Araucanía and Maule, that's the Malco cohort. We are continuing with our 1-year recontact and have been able to so far recontact 88% of those women who are eligible for recontact. If you restrict that to women who are within 6 months of being past the window of recontact, that response rate goes up to 97%. So we're doing pretty well at keeping in touch with people. And just last month, we started the first 2-year follow-up visit because recruitment actually began in 2016. So again, you'll have to have me back to let you know how we're doing with our follow-up visits. So far, we are doing pretty well with our outcome ascertainment. We have rapid ascertainment systems in place, both in Araucanía and in Maule. We have had 417 surgeries to date, and again, about 80% of those, we do have completely sampled gallbladders. Accrual will go on through the end of this year, and then we'll be off and running. So just to give you a sense of what this looks like, here you can see the setup for one of the community campaigns just outside of one of the local public health centers. Here you can see our efforts at going door to door. We do have a mobile clinic, which is helping facilitate some of these efforts, and just some of the field staff who are working really hard to make all of this happen. We do have a Facebook page. If you speak Spanish, there are a couple of really nice videos that summarize the study. If you don't speak Spanish, go look at them anyway. You can still see what's going on, and we can really use all the publicity we can get, so please, by all means, do like us on Facebook. And I'd just like to finish by saying this effort, all of these efforts that I presented today, really take a lot of work from many different people. I can't possibly list everybody who's been involved, but I've really tried to list some of the key players from NCI, from the American Cancer Institute, Stanford, Shanghai, MD Anderson, Hopkins, and Chile that have been involved with all of the work that you've seen presented today. And to that end, I'd also like to thank you, because it's by having the opportunity to come and share with you that new ideas and new efforts can be generated. So I hope that I've taught you a little bit about what we're doing and maybe generated some interest in you. And with that, I would be happy to take any questions.